Hey everyone, it's Professor Costa. Today we're going to be covering medications affecting neuromuscular disorders. So there's two that go with Nursing 2040 that in particular. And those are altered protection disorders. So autoimmune, what does that mean? The body is not being very efficient and is attacking itself. The two we're going to look at today and medications for are multiple sclerosis and myasthenia gravis. So MS, you'll see the memory notebook of nursing slide with a quick overview. That will come more into play. Keep that little section of the slide for Nursing 2040. You're welcome. And then myasthenia gravis, you'll see in that picture is a classic sign of myasthenia gravis, which is that ptosis or drooping of one of the eyelids. I'm not testing you on what the disease does to the body, but you do need to know that they're autoimmune disorders, okay? And a little bit of the physiology that's in the textbook, okay? All right, so treatment of autoimmune disorders. So normally our body is able to recognize a foreign invader and it doesn't confuse things. Well, in an autoimmune disorder, our body is confused and it thinks that part of its own body is a foreign invader and it attacks it, right? So most of the drug therapies that we use to treat autoimmune disorders limit protection. Steroids, NSAIDs, DMARDs, immunosuppressive meds. Think of what we do for another autoimmune disorder such as rheumatoid arthritis. All these are, these meds are not that different, okay? So nursing interventions, when we give a steroid, an NSAID, or a DMARD, would be to promote protection, right? And then prevent any other complications like the GI complications of GERD or stress ulcers, good sleep, good rest, stress reduction. We're going to try and optimize protection in these patients as much as possible because we're impairing it on another level. Okay, so what is myasthenia gravis? One, it's an autoimmune disorder. It messes with the impulses and muscle responses at the myoneural level or junction, okay? And it's inadequate secretion of acetylcholine or acetylcholine. I was talking with a neurologist the other day and he said acetylcholine and I went, have I been mispronouncing this for God knows how many years, but I say acetylcholine. Okay, so loss of acetylcholine because of an increase in the enzyme acetylcholine esterase. All right, so what happens is these people wake up feeling pretty good, and then during the day they have increased muscular weakness and fatigue. Right, so we're having muscle fatigue. Unfortunately, muscles control lots of things in our body, and the one that we worry the most about with myasthenia gravis is respiratory muscle paralysis. That's mostly if we're giving patients anesthesia. So, if they're having surgery and they have myasthenia gravis, that's a big red flag for the anesthesiologist. They have to be very careful, okay? Ptosis, which is that drooping eyelid, difficulty chewing and swallowing. Okay, those are the big muscles that we worry about, right? Yeah, they get weak during the day and they're taught to do more stuff in the morning and yada, yada, yada. But we're mostly worried about respiratory muscle paralysis in these patients, especially if they have general anesthesia. Okay, so myasthenia gravis. The goal, since the problem is with acetylcholine, all of those receptor sites get damaged. So what do we need to do? We need to keep acetylcholine around longer. And so we block the enzyme that normally breaks it down. So we have enzymes that get released, and then we have other enzymes that clean up those enzymes, and then our body recycles this stuff over and over. An enzyme or any kind of chemical only works in the body if there is a receptor site that recognizes it, correct? For every key there is a lock. Well, unfortunately, the locks here are what get damaged, the receptor sites. So the less receptor sites mean the less efficient, muscle contractions and so forth. And so our muscles get tired. What do we need to do? So if we don't have as many locks, then we try to keep more and more keys around by preventing the keys from getting recycled. So that's what we're doing here. We're blocking acetylcholine esterase so that more and more acetylcholine is left around, and it can actually maximize effectiveness, while we still can't. So what does it do? Acetylcholine, it promotes muscle contraction in skeletal muscles. So if I want to walk across the room, acetylcholine helps my muscles do that. And then also for our heart muscle, it controls the parasympathetic nervous system, rest and digest. So without acetylcholine, our heart would just go pitter patter, and faster and faster and faster. And acetylcholine helps with that vagal response. All right. So how do we diagnose? Why am I talking about diagnosis of a disease? Well, because we use a medication to do that. So if we have someone with a suspicion of myasthenia gravis, such as a patient, and usually like female and in their 40s, that's the, the typical myasthenia patient that comes in. What we're going to look for is if she has ptosis, we would give her a super short, ultra short acting medication like androphonium or tensilon. And then if the symptom gets better, such as the ptosis recedes or stops, then they're like, she had a drooping eyelid, and then we gave her tensilon, and look, her drooping eyelid went away. Then we know that she has or he has myasthenia gravis. Okay, then we have other medications used to treat the actual disease. All right, so we have a short acting, the neostigmine, an intermediate acting, the pyridostigmine, and a long acting. So most people are usually administered something like the mestinon, that intermediate acting, to control symptoms during the day. All right, so what if they don't respond to the acetylcholinesterase inhibitor? What if those medications aren't really cutting it in terms of controlling symptoms? Well, sometimes we have to really override the immune response and do things like prednisone. So anytime we have an immune response that is inappropriate or too much, we will give a steroid like prednisone. Okay, we can do a plasma exchange where we actually like suck out all the plasma and we exchange it for different plasma, because that's where all of those antibodies are. We can give immunoglobulin or an immunosuppressant drug like Imuran, or as I can never say the generic name for this, so I'm just going to say Imuran. Okay, so this is an autoimmune disorder. Remember that. So this treatment limits protection. We know prednisone and all steroids are going to limit protection, and they come with their own list of risk factors. So why do we give immunoglobulin? Okay, so how do we get it? It's from plasma donors. So people give blood, and then their plasma is screened, and we separate the plasma from the blood, and we use other people's immunoglobulin, okay? Which is just absolutely amazing that we're able to do that nowadays. Acetylcholinesterase inhibitors are the main treatment though. So we're going to try and keep acetylcholine at that nerve junction for as long as possible so that we maximize the few receptor sites that remain. Okay, so the body has attacked the receptor sites specifically, and without those receptor sites, you're not going to have muscle contraction. So unfortunately, this is kind of tricky. So we can have overdosing or underdosing, and the symptoms are pretty darn similar, okay? So muscle weakness or dyspnea, shortness of breath, dysphagia, trouble swallowing, abdominal cramping, drooling, increases tearing and sweating, bradycardia, all right? That's overdosing, okay? Myasthenia crisis is when the patient is underdosed, so they may have trouble breathing, okay? And a cholinergic crisis is they're overdosed. Wow, that's a lot, right? So a lot of people have to like write out little charts to understand how, okay? So a myasthenic crisis is when we don't have enough receptor sites, or we don't have enough acetylcholine to act on the receptor sites, and we have severe muscle weakness, right? The big worry is if the patient can't control their muscles of breathing. So it may involve the diaphragm and intercostal muscles, okay? So the triggers are inadequate dosing. So I didn't take enough of my myasthenia gravis drug. So maybe tensilon or Another drug, acetylcholine esterase inhibitor. Okay, infection. So when my immune response is triggered for another reason, that may worsen my symptoms of myasthenia gravis and change the amount of medication that I normally need. So emotional stress, menses, pregnancy, surgery, trauma, anything that can affect my body's protection can affect how the medication works in my body. Okay. So a myasthenic crisis improves after you have tensilon and neostigmine, right? So if it's a crisis, meaning we don't have enough acetylcholine at the junction, if we give a medication that increases the availability of acetylcholine at the junction, the symptoms go away. So a cholinergic crisis is the opposite, okay? And what happens is we have too much acetylcholine. When we have too much of anything in the body, it's bad. When we have a cholinergic crisis, it's really bad. Just, I don't know if any of you out there today are military people, but this is what happens when you have nerve gas. A cholinergic crisis is what occurs. So it usually occurs within 30 to 60 minutes after taking an anticholinergic medication. So I took my tensilon or my neostigmine, and now I'm having the opposite problem. I went from not having enough acetylcholine to having way too much. So we can have severe muscle weakness, paralysis, abnormal pupil constriction, excess salivation, GI distress, bradycardia, fasciculations, and it can get worse. So a myasthenic crisis gets better with tensilon, while a cholinergic crisis gets way worse. All right, so a cholinergic crisis: salivation, lacrimation, urination, defecation. So with sarin gas, that nerve gas, this is the type of thing that happens is we have a cholinergic crisis. And the only way to fix that is to give the patient something that blocks that parasympathetic response, atropine. Okay, so again, we can have GI disturbances, increased salivation, tearing, meiosis, blurred vision, bradycardia, or hypotension. So we have an overstimulation, basically, of the parasympathetic response. So how do we fix that, or how do we prevent that a cholinergic crisis from occurring? Well, we administer doses on time. Take the drugs before meals if possible, and we're going to monitor for effectiveness. And you have to have the antidote available for a cholinergic crisis, especially if you're doing this diagnostically in the hospital, atropine. So think back to perfusion. So if we have an overstimulated parasympathetic response, we're going to have a patient who has bradycardia. Well, that's going to happen here too. And what do we give for bradycardia? Well, same thing. We're going to give atropine. All right. And we're going to encourage the patient to wear a medical identification bracelet. So, you know, first responders should be aware that this person has myasthenia gravis and is taking an acetylcholine esterase inhibitor. All right. Now we're going to talk about multiple sclerosis. Again, another autoimmune disorder where the body attacks the myelin sheath of nerve fibers in the brain and spinal cord. All right. It causes lesions or sores. Right. So a nerve that's covered in sores isn't going to work very well, right? And we can have remissions and exacerbations. Can a sore heal? Yes. So sometimes patients with MS will go through, you know, months or years of no symptoms, and then all of a sudden they can have an exacerbation. Or there are people with more progressive disease where they don't get those remissions. So we have weakness or spasticity in the extremities or diplopia. We can have paresthesias. Most patients are diagnosed with MS based on problems with their optic nerves. They get optic neuritis, and that's usually pretty diagnostic of for multiple sclerosis. Okay, so how do we treat it? An acute attack would get steroids. Not surprisingly, that we do that with a lot of acute things with the protection. Remission or exacerbation, we would consider a biologic response modifier, like interferon B, or cancer medications that would definitely cause an immunosuppression, or a DMARD, right? A disease-modifying anti-rheumatic drug. Those are all things that will limit the body's ability to attack. Unfortunately, it limits the body's ability to attack anything. And then progressive or chronic would definitely get an immunosuppressant drug. So one drug is interferon beta, right? So it suppresses the immune system. It's for patients with definite progression of their MS. This is someone that's showing signs of impaired walking or multiple exacerbations. And causes localized irritation where it's injected under the skin. We're, activating the person's immune response. And flu-like symptoms are common. So what does this do? Well, we're trying to limit the body's ability to attack itself by turning on T cells in the body called suppressor T cells. So there, for every on switch, there's an off. And for these people, we're trying to activate, I know this sounds oxymoronic, but we're trying to activate one of the off switches that we naturally have, which are suppressor T cells. But we are activating part of the immune system, so patients will feel like they have the flu. So, nursing interventions. One, we want to protect protection, right? Infection prevention and early recognition of infection. So people who are on anything that affects protection may be told to do things like take a daily temperature. So you wake up in the morning, take your temp. Any low rise in temp should be reported. If they have any flu-like symptoms, it should be reported. There's no like, I feel it a little, oh wait, I should call and let them know I feel like I have the flu. Prevention of GI complications. All of these come with a risk of GERD or stress ulcers. So what kind of prophylaxis do we do? Well, they may be put on a proton pump inhibitor like omeprazole, or they may be put on an H2 blocker like Pepcid, okay, famotidine. Promotion of optimal protection. So again, good nutrition, sleep, stress reduction, anything we can do to help promote protection. Right. So an unfortunate side effect of MS is something called spasticity, or Charlie horses, or muscle cramps. So how do we treat that? Well, a centrally acting one, baclofen, or a direct acting one called dantrium or dantrolene, or succinylcholine or vecuronium. Those are paralytics that we use for surgery and intubation. So skeletal muscle relaxants are used for either to relax muscles routinely, or for these, such as succinylcholine, they're paralytics used during surgery and intubation, and they definitely paralyze the entire body. So we'd have to have an advanced airway in place for that. Now we're going to talk about muscle relaxants used for things like backaches, or for patients who have spasticity. So a really common one for people with back spasms is Flexeril or cyclobenzaprine. It relaxes skeletal muscles, and it's used acutely. So it is anticholinergic effect, so it makes you dry, drowsy, can cause headache or fever, abdominal pain, erectile dysfunction, and Flexeril is used acutely. You don't use that for more than a few weeks. The baclofen, 2 slides before, is used more for the long-term stuff for patients who have spasticity related to multiple sclerosis.